Hi, everyone. I'm Kathy. I'm going to be talking about diagnosis via abdominal X-ray today. And I want to thank the EKG, RADS, Farm, and Tox team. A picture is 1,000 words. The overview for today's lecture, I want to go through the ABCDs of reading an abdominal X-ray, identify pathologies based on these X-rays, and I want you guys to feel more confident when you look at them. So when should we get an abdominal X-ray? You should get it if you suspect a bowel obstruction, a perforation, maybe moderate to severe undifferentiated abdominal pain, suspected foreign body, or even like a renal calculi follow-up. You shouldn't get an X-ray if there's abdominal trauma, if there's right upper quadrant pain, if there's a suspected intra-abdominal collection, an acute GI bleed, a suspected cancer, and constipation is a clinical diagnosis. You shouldn't get any pictures for that. Why don't we just get a CT? That is true. Usually we don't get abdominal X-rays in the emergency room, and most of the pathologies that we see, the next best step is going to be a CAT scan or an ultrasound. But for the purposes of this lecture, knowledge about the radiographic manifestations of these diseases and disorders is important in understanding the pathology of the diagnosis. And then the other reasons to get an abdominal X-ray is if a patient's too unstable for a CAT scan, if a CAT scan imaging will delay emergency surgery, and for kids, you know, getting an X-ray will give you a lot of information. All right, so a lot of people has asked me, like, what's the difference between getting a flat upright and a left lateral decubitus? This is the picture of how the X-rays are taken. Most of the X-rays are taken supine or flat. The patient's more comfortable. It's not really specific. It shows some bowel, soft tissue, and bones. Getting an upright X-ray is probably better. It'll show your gas fluid levels. You can look for pneumoperitoneum as well. And a left lateral decubitus X-ray is important when the patient can't be positioned upright. They might be too sick. And what you can do, you can look for free air that lines the liver edge. So what are we exactly looking at? Sometimes X-rays are called a KUB, which stands for kidneys, ureter, and bladder. You can see sort of the outlines of these solid organs here. And for the most part, we're looking at the intestinal pattern. Just like going through, number 1 is the stomach, 2 is the cecum, 3 is ascending colon, 4 hepatic flexure, 5 transverse colon, 6 splenic flexure, 7 descending colon, and 8 the sigmoid colon. And again, about the intestinal gas patterns, we see this a lot as well. For small bowel, basically, if it's over 3 centimeters, it's considered dilated. The position of the small bowel is more central in the abdominal X-ray. The mucosal wall pattern, also called valvulae convenientes. Basically, they are thin and closely spaced, and they cross the entire width of the bowel compared to the large bowel. If it's greater than 5.5 centimeters, that's considered dilated. Over 9 or 10 for the cecum and sigmoid. It's mostly circumferential around the picture, and you can see the haustral folds, which are thick, widely spaced, and they don't cross the entire width of the bowel. And the other view that we usually see the most is getting like a CT. The first picture after getting a CAT scan is you see the scout view. And we tend to skip it over, but again, it can show you a lot of information about the patient and the disease. So some systems about how to read an abdominal X-ray, the ABCDEs, look for air in the wrong place, pneumoperitoneum, pneumoretroperitoneum. You can look for gas in the biliary tree or the portal vein. B is for bowel, look for the dilated loops, large and small bowel, look for a volvulus, distended stomach, a hernia. You can also look for bowel patterns like wall thickening. C, look for calcifications. Whether it's the kidney or the gallbladder, maybe it's a AAA that's calcified. Also look for any like calcified lymph nodes, fibroids, maybe a feeble you can also see as well. D is look for disability in bones or solid organs. And E is for everything else. So look for foreign bodies, look for clips in previous surgeries, and you can also look at the lungs. And then if you don't like the ABCDs, you can also just look at gas, soft tissues, calcifications, and foreign bodies. So for the next many slides, it's super interactive. And I want you guys to look really hard at all the pictures and describe one, what you see, and two, what the diagnosis is. And every patient is different, so they might manifest in a different way. And I think I have enough slides for every resident in the room. So I'm going to start off with David. Can you describe what you see and what you think the diagnosis is?
I see particularly like in the lower abdomen and air fluid levels, and then dilation of the bowel loops.
Yeah. So this is like an upright X-ray. You see dilated bowel loops, probably greater than 3 centimeters. There's air fluid levels, so likely this is like an SBO. Great. Taylor, Murta. Sure. Maybe. So you can sort of see that the center, the size is kind of almost similar to the large bowel, but there's no air fluid levels here. It's generally all dilated, and not all this. All these pictures are the same, but this is very. This is a picture of a down X-ray in a patient with ileus. Yeah. Okay. Pierre. This might be kind of hard. Is it okay to dim the lights on the side or not really? Okay, never mind. Yes, the spine is here. If you look really close, you can sort of see calcifications right here in the right upper quadrant, right here. So this is calcified gallstones. Okay, this is a little easier. I gave you the arrow. Miguel, berries. Okay, what about the bowel gas pattern? Yeah, it's kind of hard, right? So basically here, this is a gallstone, and this is ileus. This is a gallstone ileus. You can see the valvulae convenientes, which shows that the bowel loops, the small bowel loops are dilated, and you have a dilated stomach here. Okay. Next one, Zara. Oh, my arrows giving it away. Yeah, so what do you see over here? So for this one, there's air in the biliary tree. This is pneumobilia. You see these dark lines in the center of the liver. And the most common causes of pneumobilia is having like a recent ERCP, an incompetent sphincter of Oddi. You can have like a recent biliary stent insertion. You can also have like an abnormal connection, like a biliary anterior fistula. Infection is rare, and you can also have like emphysematous cholecystitis, which can also cause air in the biliary tree as well. Okay, Christina. Yeah, you have a classic coffee bean sign and diagnosis. Yeah, so with the sigma volvulus, the next step is to get GI to decompress. Great. Jamie? Yes. So this is probably greater than 9 to 10 centimeters. If this is a sigma volvulus, this is the pictures of a cecal volvulus. This one you need surgery. So call surgery for operative intervention. You can't decompress something that's so proximal. Great. Okay, Sam. This is a scout view, by the way, of a CAT scan. This is a scout view of a CAT scan, so it's not like the typical X-rays that we've seen, but you can sort of see it, still see the same things. Yeah, large bowel or small bowel? Yeah, okay. Yeah. And let's say I say this patient is like a 90-year-old in the ICU, has been there for a while. No, you don't really see any like stool pattern here, but this is an Ogilvy's or a colonic pseudo obstruction. Okay. JMac.
They have dilated with bowel. Descending transfer.
Yeah, so all the large bowel is involved. And let's say I said this patient had diarrhea that was very watery, fever, and recent antibiotic use. Exactly. This is toxic megacolon. Great. Okay, Spencer. This one's kind of hard, actually. No. So yeah, so there's not really air, but you can see there's a colonic wall inflammation that you can lose the normal hostra as well, and there's a thumbprint sign. So this is like general like colonic wall in inflammatory changes. So in some sort of colitis or something like that. Okay, for us. Yeah, they're still everywhere. There's a lot of fecal loading here. This is constipation. Okay, Christina. Correct. So there's a lot of stool here. This is like fecal impaction. There's a lot of fecal load. Yes, this is like really bad constipation. They need a disimpaction plus more. Okay. MJ. Yeah. Yeah. So this is this is pneumoperitoneum. You see air underneath the diaphragm. Great. What about this one, Rochelle? Kind of hard. Yeah, it's kind of hard. I might give you this one. But there's pneumoretroperitoneum around here. And it sort of can tell you like where the perforation is, right? Like what kind of organs or what kind of parts of the bowel is in the retroperitoneum. Yeah, so ascending, descending cooling perforation, or you can have a duodenal perforation as well. For pneumoperitoneums, likely stomach, so gastric, transverse colon, or small bowel. Okay. Calvin. No, this one's a little easy. You see clips, right? This is a patient with the surgical clips in the right upper quadrant, probably had a closed cystectomy. The small bowel pattern and gas pattern is non-specific. Okay, Priya. So tell me what the obvious is. Yeah, there's some spinal hardware and surgical clips there as well. Okay. Kenny. Sure, this is a core body. This is a peg tube. Okay, Eli. So tell me what's the most prominent thing. Uh-huh. Correct. That's a bamboo spine and ankylosing spondylitis. Great. Great. Sarah? Here, I'll give you some hints. These over here. Yeah, these are kidney stones. This patient has bilateral renal stones. Great. Subham. That is correct. Staghorn calculi. Okay. Abner. This is a body packer. So this person has like drugs throughout the entire colon. Okay, and it doesn't, I think it's just really the packaging. I think it doesn't matter if it's like cocaine or amphetamines. I think their body packer is this what they like. Great. Ryan. Can you say a little louder? So the spleen's usually like over here. It's actually in the stomach. Yes, these are iron pills. Thank you, Dr. Sinner. Great. Let's go back to the center. David.
There's
Yes, there's a deodorant can somewhere up the rectum. Correct. Okay, Taylor. It's kind of hard to see, but there's like an outlining here where a large vessel goes right in the center of the body. Yeah, this is a calcified AAA. It's a fusiform AAA. Okay, Pierre. What do you see here? What do you see here? It's a baby. There's a baby in here. Yes. Yes. So let's transition to pediatric x-rays. For pediatric x-rays always get two views, left and upright, left lateral decubitus. You have to see air in the abdomen. If there's paucity of air, you worry about an obstruction. This is an adult, but I couldn't find like a normal peds one. Okay. I feel like you guys haven't really done that many peds x-rays, but let's give it a shot. Miguel. Double bubble sign, which is basically two discontinued loops of bowel. This is suggestive like a high or proximal small bowel obstruction. It's pathologic typically in duodenal atresia. Okay. Sarah? Correct. This is a diaphragmatic hernia. There is bowel loops up on the left lung. Okay. Christina. Yes, this is intestinalis pneumatosis. So you see like air along the bowel linings. This is consistent with neck. Okay. Jamie? Foreign body. This is a button battery. Yes, button battery. Button battery. Okay. All right, Sam. Yeah, it's contrast. Where's it come from? Well, it's not going up the rectum. So there's contrast extravasation from a G tube here. like if you had to do contrast up, which you usually don't, you should see like a contrast line up from the bottom end. But here the contrast is coming through the G tube and it's extravasating. This is extravasation of contrast for G tube. Okay. Keys. Oops. So tell me what's sort of obvious here. Yeah, there's some sort of obstruction, maybe like sepsis. There's some sort of ischemic bowel in the infant. And over here, you see all these like gas in the portal vein as sort of these branching dark lines in the periphery of the liver. For a kid, the most common causes ischemic bowel, necrotizing enterocolitis, or severe abdominal infection, sepsis. Okay, JMAC. So these are the broad wire, sure. What's this right here?
Foreign body.
Yeah, it's a foreign body. In the past, I think these are banned in the United States now. I think you have to like get them outside, but they're called buckyballs. They're just these two magnets that like kids play with. If they ingest them like one at a time, they end up in different parts of the intestine. So these magnets are not next to each other. They're next to two parts of probably some sort of small bowel. It can cause necrosis of the bowel. Okay, and this is the last one, Spencer. Yeah, so these are actually lead chips in the large intestines. Lead chips. So some kid was eating lead, or like eating paint chips from their home. Great. So I hope you feel a little bit more confident now looking at these X-rays. I'm sure you guys now like X-rays can show you a lot of things. And these are my references. Thanks, guys.